Good morning. Thank you very much for the invitation for this event. These are my disclosures. The shoulder examination starts with thorough history and a physical examination. And the physical examination is important to evaluate the inspection, the range of motion, active and passive, the strength of testings, and provocative tests. We start the physical examination with the inspection. First, we take a look to the normal side. We compare with the other side. Then we evaluate the rotator cuff muscle, the supraspinatus muscles, and the infraspinatus muscles. And then we start to evaluate the active range of motion, first with the forward flexion. Then we evaluate the external rotation at the side. After we evaluate the external rotation, we start to continue our physical examination with the internal rotation. In this case, it's absolutely normal because it's a normal patient. Then we continue our exam with evaluation the abduction to try to get all the way up, in this case 180 degrees of abduction. And we end the active with the external rotation and internal rotation with the arm at 90 degrees. Then, with the passive range of motion, the forward elevation, in this case is normal because this is a normal patient. Then we continue with the same range of motion than the active, the passive, the abduction, the external rotation at the side, and finally, the external rotation and internal rotation with the arm at 90 degrees of abduction. Then we start with the tests. The first test that we perform after the internal and external rotation at 90 degrees is the near test. Normally it's positive when there is pain when we are doing forward elevation. Then the Hawking-Kennedy test. In this case, when the arm is in internal rotation, we can have some pain. In that case, the test is positive. Then we continue with the Joby test with the empty can and the full can. When the test sometimes is positive, then we continue with the speed test to evaluate the biceps. Then the cross-arm adduction test. We are in the back of the patient and with the patient is standing. Meanwhile, we perform these tests. Then we continue with the test from the infraspinatus strength, the arms on the side. We ask the patient to do an external rotation against resistance. Then we do the external rotation lag, the arm with slight abduction. We ask the patient to maintain the arm in external rotation when there is a lag. This test is positive. It's just subspinatus and infraspinatus test. Then the drop sign with the arm at 90 degrees of abduction. We ask the patient to maintain the external rotation when the test is positive. That is a drop of the arm. Then we perform the internal lag. Then we perform, in the cases where we suspect some special kind of pathology, the Patet test. We ask the patient to perform an external rotation against resistance. When the force is less than grade 4, the test is positive. Then the Whipple test. This is a good test to evaluate the anterior superior calf. When it's positive, we can suspicion it. And finally, we perform the O'Brien test. Pain that is positive in internal rotation and is relieved in external rotation is positive. The other important test that we perform is painful arc. The test is positive if the patient has pain or is painful catching between 60 and 120 degrees. Another important test is the CODMAN drop arm sign. In this test, the patient is asked to elevate the arm fully and then to slowly reverse the motion in the same arc. If the arm drops suddenly or the patient has severe pain, the test is considered to be positive. The importance and relevance of the test. Impingement disease of any degree, the combination of 3 tests, positive Hawking, painful arc, and weakness in external rotation is suggestive of some kind of impingement. The near impingement and the Hawking-Kennedy are very sensitive about low specific for rotator cuff disease. For full thickness rotator cuff tear, the best combination of tests when all 3 are positive, the painful arc, the CODMAN drop arm, and the weakness highly suggestive of full-thickness rotator cuff tears, and a 90% of chance of full-thickness rotator cuff tears in patients with more than 60 years of age. To evaluate the teres minor, the padded test is the only test for muscular strength of teres minor in the case of deficient infraspinatus, and an external rotation lag sign of more than 40 degrees is the most accurate test for teres minor dysfunction. For subscapularis, it was mentioned 3 combinations of tests: the lift-offs, the belly press test, and the bear hug test. There is no evidence on the other side that rotator cuff tear heal spontaneously without surgery, and there is evidence that rotator cuff tear progress gradually with time, and the side progression could produce pain. There are rotator cuff tears that are asymptomatic or pain-free, but when the rotator cuff tear progresses to certain size, they become symptomatic. But even though they are asymptomatic, we can have some fatty degeneration, muscle atrophy, and less muscle strength. And for rotator cuff repair, the patient selection is very important, and the ideal patient for the repair is an active, young patient, compliant, with no fatty degeneration or muscle atrophy, and with small and medium tears. Our technical objectives is to identify the tear pattern and extension, stimulation of the healing, and to get a stable fixation of the tendon to bone, trying to restore the footprint with a good contact pressure and with decreased motion in the bone-tendon interface. Which are the limitations? Surgical repair technique, minimal limitation. The biology is the actual limitation because we can have osteopenic bone, poor tendon quality, muscle atrophy, and fatty degeneration and fibrosis. The healing rate tendon to bone after full thickness rotator cuff goes from 50 to 90%. When the tendon heals, we have better clinical result and strength, less progression of degenerative changes. When the tendon re-tears or do not heal, there is degeneration, that is, even though we have this re-tear, we have better function and less than before the surgery. The options are transosseous or suture anchors with configuration of the single row, double row, or transosseous equivalent. The recurrence rate depends on the size of the more tendon we have to repair, more recurrence, with recurrence that go sometimes to 68% and sometimes to 90%. And the recurrence increases with the time. Normally, when we have the recurrence, the 50% of the cases, the recurrence is present at 6 months and 62% at 1 year. Here we have different studies that show recurrence tears that go from 29 to 90% of the cases. When the age goes over 55 years of age, and this is a study published by Dr. Boileau, we have unhealed tendon more than 57% of the cases. Several systematic review of surgery shows no difference in clinical outcome when we perform the repair open, mini-open, or arthroscopic. Some systematic reviews show as well that there is no clinical difference after single or double row repair. But we have better anatomic repair with double row compared with single row when we examine in the MRI. Another meta-analysis showed the same, better healing, but no clinical differences when we compare double row to single row. The arthroscopic decompression, cuff repair with or without arthroscopic decompression according with this study of CODMAN 2004 showed no difference. Type 1 and 2 acromion were included. The consensus of the Upper Extremity Committee of ASACOS for asymptomatic tears is to observe, and for symptomatic tears, rehab with emphasis in the scapula, and repair may be with a single row, double row configuration depending on the size of the tear. Observation of the tears, this is study in 1998 with ultrasound follow-up for asymptomatic cuff tears. 50% of the cases became symptomatic. This other study by Moll and Yamaguchi with ultrasound follow-up of the progression, the symptomatic tears progressed 23% of the cases, and the asymptomatic always progressed, only the 4%. This other study by Saviore in 2011 with ultrasound follow-up of a small tear in patient less than 60 years of age, 50% of the cases increases in size. The recommendation is for asymptomatic small or medium tears is to observe, for symptomatic small or medium tears rehab and repair, and the subacromial decompression is recommended to create a small subacromial arc when there is the presence of an osteophyte. In summary, The best combination of tests for complete rotator cuff tear, when all three are positive, are the painful arc, CODMAN drop arc sign, and weakness in external rotation. The rotator cuff prevents the insertion pathology produced on the muscle, and the recurrence of the tear is high when we have a big tear, when we have fat infiltration, and with older patients. Rotator cuff repair tries to restore the normal insertion of the rotator cuff to the bone. Repair, small to medium tears with no retraction in young patients, probably not repair, massive tear with fatty urination in elderly patients with associated diseases because the low probability of healing. And perhaps repairs, medium-sized tear in patients that are smokers and with a stiff shoulder. Thank you very much.